Yeah, good afternoon. Good afternoon, everyone. And first, thank you for having me, and also thank you for joining me this day. Without any further ado, in this presentation, we will explore some critical rules of the ECG in recognition of arrhythmia in form of tachyarrhythmia or bradyarrhythmia. As you know, the ECGs remain the most valuable non-invasive tools in the cardiology. So let us begin our journey into the heart rhythm through the lens of the ECG. I will just start with few introduction uh, slides, couple of slides about the mechanism of arrhythmia in form of narrow complex arrhythmia and wide complex arrhythmia, and then I will go with the interactive session. My session is kind of interactive session. It's not one man show session. So once we reach that point, I need from the participants to interact with me. And I have no disclosure in my talk. In the general definition of arrhythmia, arrhythmia means any disturbance of physiologic automaticity or conductivity of the myocyte. This alteration leading to the alteration in the rate, rhythm, and even the ECG morphology. Alteration of the either impulse formation by the enhanced automaticity leading to tachyarrhythmia. A lot of things can cause this in form of atrial arrhythmia and for ventricular arrhythmia, or decrease automaticity leading to the bradyarrhythmia. Alter the conduction, the alteration of the conduction in form of re-entry can cause of tachyarrhythmia in form of as well as in the ventricular arrhythmia. Alteration of the conduction by slowing the conduction, by the blocking the conduction, leading to the bradyarrhythmia. You know the main mechanism of the arrhythmia, which is automaticity. The automaticity, the ability of the cells to generate electrical activity, and usually it is a normal phenomenon. If the altered is there is if there is any alteration of the automaticity by the increasing the automaticity in form of, could be normal at the beginning in form of sinus tachycardia, or could be abnormal alteration of automaticity in form of the atrial tachycardia, for example. Re-entry, you know, there is more than one pathway for the arrhythmia to lead to re-entry, one fast pathway and the other slow pathway, and we need the pathway to form to some delay in one pathway to conduct another pathway to recover to make it a unidirectional tachycardia, and this is the most common kind of mechanism of arrhythmia. Triggered activity in form of after depolarization, which usually after the finished, either during or after finished of the repolarization, in form two kind of the triggered activity, either early after depolarization or delayed after the depolarization. All of these things, you know, this just to remind, just a reminder. You know the paroxysmal supraventricular tachycardia. We have the most three common arrhythmia, which is AVNRT or AVRT in form orthodomic, and atrial tachycardia. AVNRT represents 60 to 65% of the atrial arrhythmia, which is in form of the supraventricular tachycardia, SVT. And usually, most of these tachycardia are AV node dependent. If you have the AV node, it's one part of the circuit. And the orthodromic AVRT and the AVNRT has two pathway, one slow pathway and the fast pathway. The fast pathway in the orthodromic usually the accessory pathway, and the slow pathway usually the ordinary conduction system, which is through the AV node. So they said both tachycardia AV nodal dependent tachycardia. The atrial tachycardia, in most of the tachycardia of atrial tachycardia, usually it's focal. It can be reintermittent, but the most common is focal. And usually it represents 5% to 10% maximum from the proximal supraventricular tachycardia. When you have supraventricular tachycardia, narrow complex tachycardia, the most important things to look for the B wave, and look to the relationship between the B wave and the QRS complex to classify it either to short RB tachycardia or long RB tachycardia. When you said short RB tachycardia, when the RB is shorter than PR interval. Here you can see this is a PR interval and this is RP interval. Here it's very clear the RP is shorter than PR interval. So this is classified as short RB tachycardia. The commonest short RB tachycardia is typical AV-NRT and other AV node reentrant tachycardia and junctional tachycardia. The long RB tachycardia, the commonest one is sinus tachycardia. The next common is atrial tachycardia and form of atypical AV-NRT and BGRT, permanent junctional reciprocating tachycardia. All of these form of tachycardia, we'll see it in our clinical or practitioner, our practical session, inshallah. So in form, if you have tachycardia, look at the tachycardia, narrow complex or wide complex. If narrow complex, if it is regular or irregular. If it is regular, look to the B wave. It's long RB tachycardia or short RB tachycardia. Short RB tachycardia, so either typical AV-NRT or orthodromic AV-RT or some other kind which is junctional tachycardia. Long RB tachycardia, the commonest are sinus tachycardia, atrial tachycardia, or junctional tachycardia. If this is narrow complex tachycardia, but it is irregular. So if it is irregular, look for B wave again. If there is no B wave, irregular rhythm, likely to be atrial fibrillation. If you have atrial activity and the atrial activity organized and usually like a flutter wave or Soto wave, it's likely atrial flutter, and this is another classification. If you have B wave, but the B wave it's not like a typical of sinus, so it's likely multifocal atrial tachycardia if it is irregular rhythm. Atrial tachycardia can be regular rhythm as well. In form of this kind of tachycardia, by the first glance, this is by definition is wide complex tachycardia. So wide complex tachycardia could be ventricular tachycardia, could be SVT with aberrancy, could be paced rhythm, could be antidromic AVRT, could be other SVT with some kind of electrical disturbance. I mean, with electrolyte disturbance with association with hypo or hyperkalemia. So how we can differentiate between this and this? Usually the most important principles, and usually you should know it, it's look for the AV dissociation, fusion beats, or capture beats. AV dissociation is more specific, and the capture beats look for the conduction beat, usually started with P wave, and fusion beat, which usually it's intermediate between the normal complex during sinus rhythm and during ventricular tachycardia. If you look carefully to this ECG, you can appreciate there is some, these are red arrow, there is some P wave, and the others there is no P wave. So this is called AV dissociation. And if you look carefully to the V1, you can find some beats here preceded by the B wave and the QRS complex like this. So this is called capture beat. The AV dissociation, if present, usually it's present in 50% of the ECG, in general speaking, and 25% of the 50% detected in the ECG. The second principle to detect which kind of arrhythmia this is it VT or an other kind of wide complex tachycardia, look to the axis. If the axis coming from the ventricles, usually the axis will be from down to up. That's mean it is to the right superior axis in this way, or northwest axis. You will find lead 1 negative and the inferior lead negative as well. And this can't be uh, other kind of wide complex tachycardia. It is impossible to happen with other kind, because nothing will come down from down, which is ventricle originated from ventricles up, other than ventricular tachycardia. The other things to look for, the precordial leads. If there is any kind of concordance in normal sinus rhythm, as you know, from V1 to V6, there is small r started in the V1 to the most dominant R wave in the V6. In the wide complex tachycardia, if you have positive concordance or negative concordance, the concordance mean all leads positive or all leads negative. This is called ventricular tachycardia. But if the some kind of, which is rare, some kind of antidromic reciprocating tachycardia, it can presented with a positive concordant, but it will not have the other features of ventricular tachycardia. But negative concordance is will not happen unless it is VT. Otherwise, it's not happen in other kind of tachycardia. As you see here, it is negative concordance, likely ventricular tachycardia. Here it's positive concordance, likely it is ventricular tachycardia. If you look for the other features of the VT, you can find or can appreciate other features of VT. So fusion beat, capture beat, it can favor VT. It's very infrequent to be seen. Usually it happened in 5% of the ECG, as the AV dissociation happened in 25% of the ECG. So if you put all of together to make a criteria or algorithm to differentiate between the VT and other kind of wide complex tachycardia, you have very key criteria which depend on the AVR leads, or other Brugada criteria. Brugada criteria depends on the presence of ARs, which is concordance in the precordial leads. And you can see if there is no concordance, you can look to the R wave, to the S nadir. If it is, I will show you in the coupling slide and other in the practitioner session how we can do these things. If the R wave to the S, if there is no concordance, look to the R to S nadir. If it is more than 100 millisecond, usually it is favoring VT, because if it is from the R to S, if it is layering, that's meaning that you are the electrical activity it's going slow conduction and the conduction tissue, and usually muscle, and the muscle in the ventricle, and likely this is VT. Look for AV dissociation, as we mentioned before, and look to the morphology criteria. Either you will find it left bundle branch block morphology or right bundle branch block morphology. Usually, if it is typical left bundle branch block, wide complex tachycardia, or typical right bundle branch block, you will favor SVT with aberrancy. But if it is atypical form of the right bundle branch block morphology, as you find one uniform R wave in the V1, or you have fractionated R wave, as you see here, or you will find some in the left bundle branch block stuttering descending limb, and usually it is not happened with typical left bundle branch block. Usually the typical left bundle branch block, you have steepy, sharp beginning of the QRS complex, not like slayering the descending part of the limb of the left bundle branch block. So generally speaking, if it is typical right bundle, typical left bundle, you should consider SVT with aberrancy. Other than this, you should consider it as VT. Regarding freaky or AVR criteria, look to the initial. If you have initial R, that's meaning this is VT. If the initial R is small or there is Q and these are more than 40 millisecond, again, this is VT. If you had much in the QRS, much predominantly in the QRS complex, likely this is VT. So these are criteria. It helps you to differentiate between the wide complex tachycardia. So from here, let us start our practice session. This session's wide difference of, you will find a different ECGs, and I need from attendee to just volunteer to read the ECG, and please introduce yourself and you can read the ECG. Let us start for sake of time. Hello?
يلا يا
Anyone
شباب
can
يلا يا شباب
anyone can contribute?
يلا يا شباب دكتور صالح asking you.
Anyone. It's just interactive session. It is like a discussion. It's nothing else.
Yes.
No embarrassment in this presentation. Just discussion between colleagues. It's okay. By the way, all of the ECGs are real ECGs, not from the internet. Maybe one or two, but all of the ECG are real ECGs. Anyone? Okay. You can see from, you can appreciate from this ECG, you can start, this is 12 lead ECG as you see, and this is narrow complex tachycardia ECG. The narrow complex tachycardia looks regular. So the second step to look for the B wave or atrial activity and look to the relationship between this B wave to the QRS complex. I can appreciate there is a B wave as you see here in the inferior leads, and if you calculate the R wave, it is very sharp R wave. The RP tachycardia, this is RP is shorter than BR interval. So we can classify this as a short RB tachycardia. So short RB tachycardia. What other features? Look to if there is anything else in the ECG. You may appreciate some kind of electrical alternance. It can happen with tachycardia, and it can happen with other kind of the cardiac problem, like if patient have precardial effusion. So short RB tachycardia. So our differential diagnosis could be typical AVNRT, could be AVRT, could be atrial tachycardia. But these patients, I know these patients, we did ablation for her. This is typical AVNRT. So this is regarding this ECG. And this is another one. Can anyone want to interpret this ECG or?
السلام عليكم.
السلام ورحمة الله.
دكتورة نمارق هذا.
مرحبا دكتور نمارق. اتفضل يا نمارق.
This is a throat complex.
Excellent.
ECG.
Excellent starting. So
Wide
it is 12 lead
complex.
ECG, wide complex tachycardia ECG. Excellent. So we have a long list of differential diagnosis, but we have to narrow our differential diagnosis to one diagnosis.
Monomorphic VT.
So your spot diagnosis is monomorphic ventricular tachycardia. Yeah. What are the features in this ECG favor ventricular tachycardia? Why not hyperkalemia, for example? with tachycardia? Why not SVT with the other? Why not paced rhythm? Why not antidromic ventricular tachycardia? Why not?
Regular?
All of the what I mentioned regular. All of them it present with regular tachycardia. What else?
Monomorphic?
So
Uh, rate about
rate about 160.
You have capture beat and fusion beat.
yes.
Where is it?
V1?
Where is it? Where is he mentioned? Someone mentioned capture beat and fusion beat, and this is nice observation. Where are they? يا ربي لكنود. Can let him to just mute his phone, please. So Namarek, if you look, let us take one by one. So you mentioned likely ventricular tachycardia, and I agree with you 100%. Let us apply one of the criteria. Look, finish. First of all, look if there is any concordance or no. Look at the V1, V2, V3, 4, 5, 6. Is any positive or negative concordance here? Yeah, there is negative concordance here. Okay. The second step to look for if there is any capture beat, fusion beat, or something, AV dissociation. Look to the rhythm strip. If you look to the rhythm strip, you will find some humps like this one and like this one, and there is nothing here. There is nothing here. Maybe here, maybe here, and the hump at the over T. So there is some B waves, and the other leads or other beats doesn't have these P wave. So we have AB dissociation. The other things, if you complete looking to the rhythm strip, you will find some narrow complex beat. And this is preceded by P wave and then conduction. Conducted through the normal conduction system. So this is called capture beat. And if you look again to this beat, prior prior the capture beat, it differ from the other beats. It's likely to be fusion beats. So we have a lot of features here to favor ventricular tachycardia. So good. So this is likely ventricular tachycardia. Why? Because of the what we mentioned before: concordance, AV dissociation, fusion beat, capture beats, and there is other features, but let us discuss it in other ECG. Okay, good. So yeah, anyone?
Why is QRS complex tachycardia?
This is also like
Okay, introduce yourself, please. I need to be fair.
this also
We
wide
have
compass.
more. We have more than 1,000 ECG. I need to do a lot of ECGs. So the practice is it makes you better than to just listen to the talk. So this is again what complex tachycardia. The next step to
Yes.
see is it regular or irregular.
Look at rhythm strip.
Yeah, look at you have a rhythm strip down.
Irregular.
So irregular. So wide complex tachycardia irregular. So if wide complex tachycardia irregular, It
Yes.
can't be ventricular tachycardia, isn't it?
Yes.
Yes, it can't be. So one of the differential diagnoses out. What makes wide complex tachycardia and irregular? If you have something like this, to look for something else, what are these things to look?
Mm. Pre-excitation.
What is it?
Forçat de voix, pre-excitation.
You can see pre-excitation. It's excellent. Where is it? It is some. If you look to the V2, yes,
V1, V1, V2.
V2 better. If you look to the
Yes.
V2, there is some skinny QRS complex with pre-excitation, and others not.
Mm.
So, and if you look to the V6 as well, it's as well clear.
Yes.
So, what is the complete diagnosis of this ECG?
What Parkinson
Syndrome only, or there is other rhythm with it? So you can say this is
is
atrial fibrillation with pre-excitation,
at is
or
pre-excitation. Yes.
WBW. Excellent, excellent. Namaric again. You are Namaric,
Yes.
huh? Okay.
Yes. Yes.
خلاص, okay. By the way, this patient cardioverted, and this is his ECG. What do you think, ya Namaric? Complete. This is his ECG during sinus rhythm. What do you think?
Uh, White complex. Some width of QRS complex.
So it's wide-ish Caris complex, a rate about 70, 70, 65, like this. What else?
Yes. Uh,
What is characteristic things here?
there is
Yes, if you look to the BR
positive,
interval,
positive.
you will find short BR interval, isn't it?
Yes.
And you have other things. If you look to the V1, you have the negative delta here, and the other
Yes.
leads there is positive delta. So short BR interval, sinus rhythm, delta wave. So this is likely WBW, and the patient
Yes.
develop pre-excitation with atrial fibrillation. So if the patient presented to you with this ECG and you are covering the emergency room, what is the most important things to look for?
Um,
Yes, look.
Avoid an LV blocking agent.
Before that, make sure your patient status or his condition is stable. Look to his hemodynamics. If his hemodynamics are stable, you can you you think about what you mentioned. If the patient hemodynamically unstable, what you will do?
Cardiovert.
Cardioversion.
Yes.
Cardiovert anyway. So if the patient hemodynamically stable and you have facility to and access for some medication, what are medication you can give to this patient?
Beauty. Beauty.
Butylide, yes, one. And what others?
Butylite.
What others? The most famous medication, it comes always in the exam. Procainamide, okay? Procainamide.
Brocanamide.
Excellent, excellent. So I need someone else. Uh, Again, this is the same pre-excitation, no, nothing new. Okay, this is difficult a bit. Yalla. I need someone else. This is young boy. He is about 5 years old. Presented with this ECG.
This ECG tachycardia.
Who is this?
Yes, Dr. Salma.
Dr.
Is
Salma, go
delta
ahead.
wave, delta wave, and short PR interval.
Are you seeing this patient? The same ECG I am looking to?
Look, there is a delta wave
Yeah.
and short
This is
PR.
the slide is the ECG is the paper is red or green?
Yes, yes.
Red.
What? Red. So read it well. Look at it very well.
BR, short BR.
It's not. Yes,
Not
agreed with you. Short BR interval. Yes. Okay.
في delta
But
wave.
what is the ECG? There is no delta wave, by the way.
No, delta wave.
There is no delta wave here.
There's an inverted BF inferior lead.
So this is 12 lead ECG, Dr. Salma. Is tachycardic or non-tachycardic? Or it's no tachycardia here?
Yes, tachycardia. Yes, there is tachycardia.
So there is
About the
12 lead ECG with narrow complex tachycardia. Okay? And the other things to see the relationship between is the B to the QRS complex. Is it short RB or long RB tachycardia?
Short.
What kind? Huh?
Short.
Short RB? يعني look did you see my arrow?
Yes.
So this is
Yes,
R, isn't it?
Yes.
This is R. You look to the B. This is the B, isn't it? هذه RB this is BR. So which is shorter?
The shorter. BR shorter.
BR shorter. That means this is long RB tachycardia. What are the differential diagnoses of long RB tachycardia? Could be sinus.
Tachycardia.
واحد. Could be others. What other differential? Could be atrial tachycardia. Could be BGRT. You know what is the meaning of BGRT?
This is supraventricular tachycardia.
Huh?
لا, I don't know.
No. Permanent junctional reciprocating tachycardia. Permanent BGRT. Permanent reciprocating junctional tachycardia, or atrial tachycardia, or sinus tachycardia, or atypical AVNRT, sorry. So these are four differential diagnoses for this ECG. So if you look to the B wave long RB tachycardia, considering the patient is young patient, and the B wave is inverted, likely it's not sinus tachycardia. This is number one. So atrial tachycardia is possibility in this patient, and the other one is BGRT. By the way, this patient ablated, and there is a accessory pathway, and the pathway is usually in the posterior septum, and this is called permanent junctional reciprocating common in young patients, and these are usually be presented with the cardiomyopathy because of tachycardia-induced cardiomyopathy. After the ablation of the accessory pathway, treat patients for a while, and he will be completely recovered. We need to discuss more ECG, please. I need to contribute fast.
Hello, Dr. Saleh.
Yes.
Yeah.
So anyone can contribute here? So I know it's a bit a tricky ECG, but we need to anyway. So the ECG, if you look carefully to the ECG, from first glance you will find it's wide complex tachycardia, which is not wide complex tachycardia. If you look carefully to the R wave, so it is very fast tachycardia. Looks a bit wideish. If you look to the V lead to a wideish tachycardia, uh, and it is regular. I honestly speaking, I can't appreciate any B wave, so I can't say this is long RB or short RB tachycardia. But this patient, if you look to the inferior leads, if you look carefully, you will find it's like a slow tooth, but it is 1 1 1 like this. And if you upside down the ECG, you will find it like sawtooth. So this is atrial flutter with 1-to-1 conduction. I know this is the tough ECG and can't be easy like others. Anyway, this is easier ECG. Can anyone contribute here?
Yes, this ECG, there is
Yeah.
bradycardia,
So
sinus
which kind of
bradycardia.
bradycardia? أيوة, excellent. You should mention which kind of bradycardia. So it is sinus. We are cardiologists. All of the attendee cardiologists, isn't it?
Mhm.
Yeah. So you should be very specified in your. So sinus bradycardia. So sinus bradycardia. Agreed. What else?
Sorry,
And
Dr.
also,
Saleh.
Yeah.
هي طبعا most of them are medical registrars, medical officers, and
ما شاء الله ما في مشكلة. Good. Excellent.
no.
So okay. Even though I remember when I was intern and in Wad Madani hospital and also medical registrar, we are
Yes.
receiving all kind of these. I think in Sudan, no difference between the cardiology fellowship and the internal medicine registrar because they are exposed to a lot of cardiology emergency and cardiology cases. I think that since I was in my training, I am exposed to all of kind of these things. I'm not sure that it's still like this till now. I hope it's still like this till now. Anyway, continue,
so there
Doctora.
is, yes, and this high uptake of T wave.
Yeah. One of the
T wave.
things here, the T wave is huge, big, tinted, maybe tinted T wave. What
Yes,
else?
yes. And
I think
also
you have a
prolongation,
session. Yeah, you
QT.
have session. You have session with Dr. Khairallah. He described some kind of uh, uh, how you organize the ECG reading from step by step. If you apply it for every ECG, you will find yourself
Yes,
at the end. You can read every single ECG. So here, as you mentioned, sinus bradycardia, and you mentioned some artifacts, and there is T wave. It's abnormal. Yes, agreed with you. What is the striking things in this ECG? You will be very worrisome about this one patient.
Prolonged QT.
طيب.
prolongation
طيب,
of
طيب, the other things. This patient, if the patient has malaria,
yes.
what's your concern to give this patient? Which kind of medication you will give this patient?
Kidney.
Or upper respiratory tract infection or something? what I am pointing to.
You point about six sinus syndrome.
No.
prolonged QT interval.
prolonged
Yes.
QT كمان.
Who's this one? Who's this? مين معي؟ دكتور مين؟ يحصل لكم vanishing بسرعة يعني. So أحسنت. I'm not sure who's talking. There is a very long QT. Long QT. If you calculate it from here to here, it's very long. Very corrected more than 600 millisecond. So long QT. In those patients, you will be very careful to give them medication leading to more further prolonged QT and leading to the ventricular arrhythmia and sudden cardiac death. One of the commonest arrhythmia medication, which is macrolides, anti-malarian, and antibiotics, macrolides. Excellent. So sinus bradycardia, the most important things in this ECG is long QT interval. Good, excellent. By the way, this patient was admitted in the ward. مين معي الدكتورة مين؟
دكتورة سلمى.
دكتورة سلمى. This patient these are real patients. This patient was in the ward and the nurse coming to you and is shouting and she is showing you this one. What do you think? What happened here?
ترسال ديبوا.
Yeah, go ahead.
ترسال ديبوا.
Torsa de bois. Yeah. Why?
Yes. Prolonged QT.
Yes. You can appreciate here if you look carefully. This is this sinus beat, and there is a BVC come R on T because of
Yes,
long
R on
QT,
T.
R on T, and then the patient went to the polymorphic ventricular tachycardia. Excellent, good. طيب, anyone can contribute here other than Salma and Namarik?
This VT.
This is what?
VT. Ventricular
VT.
tachycardia.
Who's this
Yes.
again? Salma?
Yes.
Yeah. Carry on, yalla. Why VT?
This wide QRS and
So
rhythmic.
it's wide co-Rs
Sinus
complex.
rhythm.
Yes. And again?
Sinus rhythm. No.
How can
regular,
sinus rhythm
regular. معلش, sorry. Regular.
So you mean this is what complex tachycardia and it is regular. So and we have a long list of differential diagnoses. So which kind of tachycardia this? Is it VT or some other wide complex tachycardia? Which is which?
This is VT.
Yeah. If I am in the ER, I will consider it VT, yes. But why? Some interns come to you, please explain to me why you consider this VT. What's your answer?
This quite quite QRS
Yeah,
and
yes, maybe a bit quite wide. What else? It's not يعني that much. What else?
Fusion page بيوان.
ها طيب look at the V1. V1 it is right. V1 is right bundle or left bundle?
Right.
Right
So
bundle.
طيب right bundle, is it typical or typical atypical right bundle?
Atypical.
So number one, atypical right bundle branch block, so it is VT. Okay, look at the, for example, lead 3. Look at the lead 3. This beat, why the beats are variable in shape? Even look at the rhythm strip, there is beats different from other beats. Why? What is the reason for that? These are fusion beats. These are fusion beats. When the beats it's different from the others, likely fusion beat. If it is narrow preceded by the B wave, likely capture beat. If you look to the AVR lead, if we have dominant R, this is likely what? Likely VT. Okay, all these features pointing towards VT. Okay, thank you. So, okay. Okay. Anyone?
الاي سي جي ده وراكم له دكتور حاتم يا شباب في المحاضرة اللي فاتت، شفتوه؟
يعني شالوا من الدكتور حاتم يعني. طيب يلا يا شباب، البيشنت دي blood pressure 80/60. What do you think? What you will do? يلا يا شباب.
This patient dorsal depot.
طيب تورسا دي بوا, this patient 80/60. What you will do?
Magnesium sulfate.
مغنيسيوم سلفيت ما نفعها.
دي
اديتيها
سي شوك.
دي سي شوك. Why دي سي شوك؟
بس هيمودايناميكال يعني ستيبل.
Why طيب؟ Why you will give اي هيموديناميك انستيبل تدي شوك؟
This shockable rhythm.
Shockable rhythm. What are the rhythm? What is the rhythm here?
Ventricular vibration.
متأكدة؟ طيب look. طيب
تاكيكارديا
او فنتركل زي ما قال الشباب. look all to the ECG ككل. look at the lead 1. في عندك بي ويف كيارس كومبلكس، بي ويف كيارس كومبلكس، صح ولا انا غلطان؟
ايوه صح.
طيب look at the other leads, all of the ECG done at once, simultaneous printing, so all of the recording are simultaneous. يعني ما ممكن يكون في lead 1 sinus وليد 2 بتكون what VT او polymorphic VT او whatever، صح ولا لا؟ صح ولا لا؟
ايوه.
So this is likely artifact. All of these artifacts simulating ventricular arrhythmia. And if you look carefully to the rhythm strip, you can march the R wave in between. You can march the R wave in between. You can find it. By the way, this is real ECG. It's not from the internet, by the way. This is a real ECG in our patients. So this patients, this is a lot of artifacts. So this is artifact. You will say the blood pressure is 80/60. So maybe other reason for low blood pressure, but it is not this rhythm because it is artifact. And if you have one lead, no artifact, this one lead one against other 12 leads. other 11 leads. So if you have one lead, the one lead one. Others, likely it is artifacts. Clear?
Clear.
Okay. It's this is a bit difficult, but I'm not sure can go through it or not. This is one of our patient. I will give you a hint. This is a 50 years old male. He has dilated cardiomyopathy. This patient is in optimal medical therapy regarding heart failure. He has sometimes history of atrial fibrillation and other stuff, and they start him in medication, beta blocker, sometimes amiodarone, and they stop it because of complication of amiodarone, and they give him digoxin. This patient presented with this rhythm to the ER. Anyone? I know this difficult ECG, but let us contribute together. Let us share the idea. Share the idea with me. شباب. دكتور دسوقي, how يعني, do we have more time or just we have
Yes, we can have another 30 minutes, inshallah.
3-0?
Yes, 30 minutes, yes.
Okay, good. Yes, so can anyone contribute? I know this is a very, very weird ECG, but you may find it
This
some.
ECG in case lead there is ST depression and
There is
inverted T wave
uh-huh.
V2 and V3.
Mm-hmm.
Okay, and is there some elevation here? And in to lead 2 and lead 3 and APF. This looks like digoxin toxicity.
يعني
Mm.
I'm not sure I can say yes or not, but yes, I will help you a bit. If you look to the rhythm strip, if you look carefully to the rhythm strip, or for example V1 or something, you can find two different QRS complex.
Yes.
All of the QRS complex are wide. We have to agree
Yes.
about this. Look to the lead 3, lead 2, both of the QRS complex. This one, and there is another QRS complex beside it. It's different a bit. This axis down and this axis up. This is down
Yes.
and this is up. This is
Yes.
down and this is up. This is down and this is up. This is down and this is up. This is up and this is down. So it's look right bundle and then left bundle, right bundle and left bundle, right bundle and left bundle, right bundle and left bundle. And the rate is a bit high, more than 120, 130.
Yes.
And if you have alternating right tachycardia with alternating wide complex axis, this is called bidirectional ventricular tachycardia. And the main cause of this in this particular patient is digoxin toxicity. So you are right in the last part of your answer. It's digoxin toxicity, but it's causing what we call bidirectional ventricular tachycardia. Yes, I know it's tough ECG, but forgive me for this. Just you will see it at some stage. It's very rare to see it, but you may see it at some stage. So this patient, homeless patient, came to you to the ER, and you did the ECG. You will find these things. What do you think? What is the ECG finding, and what's your diagnosis? Honestly, I expect a lot of people contribute because I know the ECG is some things, especially in some ECG stuff, but it's good to interact, to know your where's your knowledge and what's wrong in your knowledge to correct it. Okay.
في short T يعني في T wave أو short
Short of what?
يعني T
Uh, I hear
short QT.
short QT. Are you sure? So
It's pericarditis.
who is with me?
محمد الطيب.
يلا محمد، خليك معي يا محمد يا اخي. من قبل مع الدكتورة ديل، خلينا نريحهم شويه. خلاص امسك الدفه يا محمد، يلا go ahead.
Yes, this is 12 ECG leads with P wave. I think it is short BR, short. You hear me?
Are you mentioned? You are right. This is 12 lead ECG. And if you look to the rhythm strip, you will find there is B wave and there is Chiara's complex and there is another T wave. Did you see my arrow?
Yes.
So the BR interval, it's not short. It's
Yes.
long. It's long.
Yes.
Maybe it's a bit prolonged BR
Prolonged,
interval.
yes, prolonged BR.
So what else?
Then we see sloping in the T wave, down sloping.
There is something very weird, and so the rhythm is sinus, isn't it? Sorry, I'm sorry. The rhythm is sinus, isn't it?
Yes.
Yeah, we have sinus lead. So, but which sinus? Sinus, normal sinus rhythm, sinus bradycardia, or sinus tachycardia?
Bradycardia.
So sinus bradycardia with borderline prolonged BR interval. Excellent. And you mentioned there is abnormal weird QRS complex. As you mentioned,
Yes.
there is something here
Yes.
at the end of the QRS complex. What is this?
This is high J wave.
Excellent. High G wave. What are the high G wave syndromes? You have a lot of differential diagnosis.
Hypothermia.
Aywa, yes. What is called? What is this called? What is called in hypothermia? What we can call this?
Nutritional or
Must not. What is the wave? This is wave called in the hypothermia. What we can call this? come in the exam always يقول لك what is this wave hypothermia indicating this is hypothermia and this is hypothermia.
في دكتورة نجلاء، دكتور صالح
يلا go ahead. اسمها
كتبت،
ايش؟
الدكتورة نجلاء كتبت في الشات قالت اوسبورن ويف.
excellent excellent دكتورة نجلة excellent. انا ما قاعد اشوف
الشات.
الشات لكن دكتور دسوقي instead of me. So excellent. So Osborne wave. This is Osborne the high G wave. Osborne wave long BR interval. دكتور محمد باقي واحدة تكمل جميلك فيها. كمل جميلك فيها. What is this? From here to here.
depression of depression of
No.
interval.
No. The QT interval is short or long?
Long.
So very long QT. So sinus bradycardia, first degree AV block, Osborne wave, long QT interval equal hypothermia. Hypothermia. Excellent all. Excellent. Yalla. This patient is 80 years old, presented to the ER with sudden left-sided weakness. And this is his ECG.
There is deep inverted T wave.
So again 12 lead ECG. دكتور محمد ولا مين؟
لا هذا حسن.
الدكتور حسن. يا مرحبا دكتور حسن. So this is 12 lead ECG.
Yeah.
So we can appreciate there is B wave صح? And there is QRS complex. So this is likely sinus rhythm.
Sinus
bradycardia or tachycardia?
bradycardia.
It's يعني 60 could be borderline bradycardia. So okay, what is striking things in this ECG?
Obviously في deep T wave inverted T wave.
Yes, there is huge T wave inversion. Huge T wave
Most
inversion.
likely due to intracranial hemorrhage.
Excellent. So likely due to intracranial, this ECG doesn't mean the patient has ischemia, but the patient has something in the brain causing this. And what is in favor انها تكون brain pathology rather than something else. الQT هنا كيف؟ Is long or short?
QT long.
So excellent Hassan. So sinus bradycardia, long QT, deep inverted T wave in the most precordial leads and the other limb leads. Likely this is cerebral pathology. Excellent.
Thank you.
يلا. Anyone else can contribute here? What is this kind of ECG? نخليكم will slow the rate بدل ما نخليكم tachycardic نخليها شوية a bit bradycardic. يلا.
Mobis type 2.
طيب حسن مين؟ again حسن؟
حسن.
ليه يا قلت لي موبس تايب 2؟
في constant BR interval.
there is what is it؟ BR interval مالها؟ constant. طيب so
there is drop QRS.
where is drop؟ هل drop يعني في
أيوه
الدروب هنا اللي تشوفه هنا واللي تشوفه هنا، هل في دروب للبي ويف ولا للكيو ار اس كومبلكس؟
الPRS
طيب وين البي ويف؟ طيب what is the B wave? So
الDF ما موجودة ولا.
it's not there. So
أيوه
you can't say this is drop QRS complex. So this is drop B wave. So
أيوه
there is pause, and the pause there is no B wave and no QRS complex, and then the sinus rhythm resumed. So this pause, what could it be? So it is not Mobitz 1 because there is no B wave. Are we
بريما
in the same? Huh?
بريماتيور اتريال
Excellent. So could be premature atrial, but where is this atrial activity? ما شايفها أنا. Where is it? ما شايفها.
فيوجن
ما في ولا فيوجن ولا هم يحزنون. So معناته لما يكون في بوز وما في ساينس بيت، ايش حصل للساينس بيت؟ محبوسة ولا ريليزد؟
محبوسة.
محبوسة. نسميها شنو؟
not conductive.
يعني شنو؟ in other way sinus exit
block.
ايوه، زي ما فيه AV block في sinus exit block. So the B wave is there but it can't be exited. It did not exit from the sinus node. So how we can prove this? We should be the pause should be double the BB interval. So if you calculate this is from here to here, it is usually double the two. مثلا from R to R for example 1 2 3 4 5 6 7 ونص هنا. طيب عندك هنا نص 1 2 3 4 5 6 7 the same. شفتي 7 ونص هنا 7 ونص البوز 7 ونص. So if it is double or triple the BB interval, the pause without B wave like called sinus exit block. Sinus exit block. If the patient symptomatic, for device therapy. If the patient asymptomatic, observation. Okay. طيب. I will stop at this ECG. So after that we'll stop and we can arrange another session if you want. But if we arrange another session, I need the attendee to contribute more. I have more than 1,000 ECG. So all of the ECG are real ECG, and this is very nice ECGs. We should contribute more and more. But let us finish with this one. Can anyone comment on this ECG? By the way, it is a bit tough ECG. It's not easy ECG. Anyone, and I will help.
Please T wave inversion.
مين معي؟
anterolateral reach.
ايش اسمك يا اختي؟
نمارك.
What's your name?
نمارك.
نمارك. طيب يا نمارك. So this is 12 lead ECG showed sinus rate. So there is B wave.
Yes.
Always start with this.
Yes.
So sinus rate, sinus rhythm, ECG. You mentioned what?
There's T wave inversion
Inversion
anterolateral.
when? Where is?
Anterolateral leads.
Mention the leads, please.
B1, B2, B3, B4.
Okay. So
And
T wave inversion.
upright B5, B6.
طيب خلاص. So there is T wave inversion. this patient normal coronaries علشان لا تقولي اسكيميا، ما في اسكيميا عنده.
آه. آه.
else.
آه.
طيب سؤال يا نمارك، صح؟
Yes.
طيب نمارك، هل النورمال انه يكون الفي 1 لايك ذس، يكون فيه ار وبعدين
No.
اس وبعدين تجي at the end of the class complex there is something here، صح؟ زي fractionation هنا، صح؟
Yes.
وكمان V2 as well، و even V3 و T wave inversion. T wave inversion is not usual in V1 to V2 V3. What could be the pathology cause this change؟ أنا مارك are you cardiologist؟
No. I'm internal medical doctor.
Internal medicine, good. It's tough. I mean, anyone cardiology here? Any cardiologist here?
Could be sodium channelopathy.
Could be sodium what?
Channelopathy, like Brugada.
Brugada. But it is not like a Brugada. It's curved T wave. I will show you some Brugada pattern, but here it is not. Look at the end of the fractionation. What could it be يعني? What could be cause of this one?
Yeah,
طيب.
Saleh, it's not this arrhythmic.
What is it? مين قال؟ مين قال إبسلون؟ مين قال إبسلون؟
مي دكتور إيمان.
دكتورة إيمان، يا سلام يا دكتورة إيمان، ليه قلت لي إبسلون ويف؟
اللي هو there is negative deflection at the end of QRS.
It's not negative, usually abnormal abnormal repolarization, initial depolarization or repolarization at the end of the QRS complex, and this is called epsilon wave, and this is with T wave inversion V1 V2 V3, and it is not usual ECG finding in other in the normal ECG. So this is absolutely abnormal ECG. What could it be the cause of this abnormal pathology or abnormal ECG?
Arrhythmogenic right ventricular cardiomyopathy.
Excellent. So very good. So this is ARVC or arrhythmogenic right ventricular dysplasia, can presented with epsilon wave and T wave inversion V1 V2 V3, and these are major or minor criteria.
Major.
These are major criteria to diagnose ARVC. I will stop at this stage. If you have time, we can meet together again with you and all of the other colleagues. But I hope to contribute more and more. I'm sorry, forgive me. My slide a bit difficult, but the difficult it make your life easy, inshallah. أما دكتور دسوقي, I think I should stop at this stage.
Okay, thank you very much, Dr. Saleh, for this elegant talk. This is very nice and very excellent. Really, we need more sessions, inshallah.
No problem. At anytime I'm willing.
بإذن الله إن شاء الله حيكونوا الشباب الليلة، ما أعرف شكلهم عندهم ظروف، ما كانوا كتار وما كانوا مشاركين، لكن
ضربوا
إن شاء
الفول
الله
ضرب ثقيل.
المرحلة الجاية إن شاء الله. دكتور صالح، لو في الإي سي جي ده يعني if you look to the rhythm strip and to the shape of the P wave، يعني could it be wandering atrial pacemaker with this different
هو
shape?
usually yes. I know someone will mention why the B wave is like this, why it's not beautifully rounded, one shape B wave.
Yes.
But if you look carefully to the rhythm strip, there is a lot of artifact.
Mm.
A lot of artifact. Look at the AVF, it's beautiful B wave. Two
Okay.
consecutive B wave, it's beautiful, nothing abnormal. But this patient was anxious patient. I know him very well. He came to me, the clinic, and he is presented with cardiomyopathy, and they put for him ICD. He received shock from the ICD and ablated twice. I did this 12 lead ECG. We find this abnormal pathology, and this is a very characteristic. And we couldn't do MRI uh, to diagnose the ARVC from the MRI, but we diagnose it from this ECG finding. The patient ablated. So we went to epicardial. We did epicardial ablation because those kind of patients, they have epicardial substrate and endocardial substrate. You should map and ablate both substrate and epicardially and endocardially to get rid of these kind of ventricular arrhythmia. Yes, I agree with you. Everyone, you can say this is some kind of wondering, but it is not. It is just a kind of artifact.
Okay, thank you very much. We have a message from Dr. Hatem Khairallah. Really, and I thank him very much. دكتور حاتم هو اللي عرفنا عليك دكتور صالح يعني ويعني كتر خيرك على المحاضرة الرائعة جدا دكتور حاتم.
You are most welcome, you and all of my colleagues in Sudan, and this is the minimum things I can do for you يعني.
الله يديك
But
العافية.
anytime you need me for any talk, I'm very willing.
Okay, thank you very much دكتور حاتم.
Thank you so much.
دكتور حاتم بيقول thank you دكتور صالح. Really appreciated your lecture. Surely you have to get them a second session. And Dr. Dasugi will arrange for that. This is message from Dr. Hatem Khairallah.
Okay, thank you so much.
If you don't mind, we will arrange for another session next
No problem.
Tuesday, same time, inshallah.
I don't mind. I don't mind at all.
Okay. The title will be again ECG and arrhythmias.
Yes, ECG and arrhythmia, because we didn't cover all of the talks because we just collect. There's a lot of kind of arrhythmia to see, a lot of bradyarrhythmia to see, to make it to practice it very well, and to rehearsal it very well.
Okay, inshallah. Do you have any questions to Dr. Saleh?
Yeah, I'm very willing. Anyone can talk. Ask. I'm happy.
You can allow me just to talk?
Yeah,
okay,
go ahead.
Welcome.
That's me, Nagla, Dr. Saleh. You remember me? Dr. Saleh is my colleague in Gezira University, batch 22.
21.
21, yeah. And Dr. Dasugi is my colleague in the cardiology fellowship.
Welcome, Najla, my classmate. I'm very happy to have you here, Najla.
It's very nice session. I'm very proud to gather together my colleague Saleh and
Really, it is nice to meet you again through the virtual meeting with the other colleagues.
Yeah, this is very nice, Saleh. I appreciate that you are still participate in teaching our colleague in Sudan. Thank you very.
This is the minimal things to do or to offer.
Yeah, this is very nice talk. In spite of that, I'm coming late in the session, but really, I appreciate this from you, and this is very nice.
Thank you, Dr. Najla. Thank you.
دكتور دسوقي ودكتور صالح يا أخي.
study. طبعا it is my mentor. My mentor, by the way.
أنا طبعا شايف صالح يا شباب يعني he was always asking for when he can participate and contribute to this, and he keeps asking me that he's always ready to dive in anytime we call him. فيا شباب استفيدوا لأنه دكتور صالح is one of the greatest electrophysiologists in the region. And by the way يعني الآن انتوا مثلا هو he did not spread يعني his wing as wide as he should and he always does. ليه simply لأنه that's why I suggest for the second session إذا دكتور صالح مثلا بيديكم ال ECGs يرسلها لدسوقي and Dasugi is gonna send it to all so you can have a chance to look at it and do your preliminary analysis and then with Dr. Saleh you elaborate on the analysis because Dr. Saleh is the best who can analyze the ECG in a very tiny detail. So don't miss this opportunity لأنه if there is no participation there is going to be staying on the surface of it لكن هو he wanna dive with you as deep as possible and I think the way out is إنه you have a look at the ECGs before, so you become kind of initially ready to start the analysis with him, and he's taking you deeper and deeper. So yeah, Dr. Saleh, if you don't mind,
sure. I
ترسل
don't mind.
ECGs القادمة لدسوقي ودسوقي يرسلها ليهم وهكذا.
Sure.
Okay.
يعني نحن بنشكر يعني أستاذنا دكتور حاتم خير الله، ونسأل الله سبحانه وتعالى إنه يعني يبارك فيك ويبارك في أيامك. يعني يا دكتور صالح، دكتور حاتم ده يعني راجل غايته بس ربنا يبارك فيه يعني.
باين أكيد ما شاء الله.
ويعني he is always with us يعني helping us during the rotation in the fellowship. He is available to us when we call him to teach our registrars. I thank him very much. وبرضه يعني نشكره الشكر الجزيل إنه يعني عرفنا على رجل عظيم زي دكتور صالح
الله
البصري.
يكرمك، الله يكرمكم جميعا إن شاء
وأنا
الله.
زي ما عرفت إنه دكتور صالح أنت من اليمن وقريت في جامعة الجزيرة،
أي
ومن
نعم.
من الناس المتميزين جدا في الإلكتروفيسيولوجي في السعودية يعني.
But remember, yeah, Disugi, he is full-blown Sudanese, by the way.
يا
Yeah,
أخي ما شاء الله.
he is Sudanese, exactly.
ما شاء الله ما شاء الله، نحن
Dual
سعيدين.
citizenship. Yeah.
اوكي، سعيدين بكم جدا والله، وربنا يعني
الله
يبارك فيكم
يكرمكم
وفي
جميعا.
ايامكم ان شاء الله. في
آمين
سؤال ثاني يا
آمين.
جماعه لدكتور صالح، دكتور حاتم، في سؤال ولا نقفل السيشن؟
Yes, I have a question.
اوكي
تفضل يا
تفضل.
دكتور أنا مالك.
In AVNRT كان بلقى البيبي قبل وبعد وزن ذا كيو ار اس، وكيف أعرفها يعني أفرزها؟
Usually the classical EVNRT, you will find the QR, the B wave is usually after the QRS complex. And if you look to the inferior lead, you will find it's a kind of something inverted called pseudo S wave. And if you look to the V1, you will find it some notching after the QRS complex. Looks like a pseudo R wave. So if you find arrhythmia with short RV tachycardia, narrow complex, and the B wave looks like a B wave followed the QRS complex with a very short, with looks like a S wave, and the R wave in the B1, prime R wave in the B1, so called pseudo R wave, this is likely EVNRT. And we have a lot of ECG in the coming slides about the EVNRT with different ways. If you see it, after you see these kind of, sometimes you will see this is EVNRT, sometimes you would see this is AVRT, sometimes you see AT, but even at the end, the table of the truth will differentiate between all. But what is important now to differentiate all of these things from the available information from the symbol or from the length of the ECG. So the length of the ECG, look for B wave, look to the B wave in the inferior leads, looks like S wave, pseudo S wave, and look to the B wave in the V1, looks like prime R. This is likely EVNRT.
اوكي thank you very much دكتور صالح. thank you very much دكتور حاتم خير الله. thank you
Thank you.
all to our
Thank
colleague.
you. I appreciate this opportunity. I hope to meet you again, inshallah. Have a nice afternoon, and thank you all for attending. Shukran, Dr. Dsugi, for this meeting. Thank you so much.
جزاك الله خير دكتور صالح، مع السلامة.
Ameen. Ameen. Assalamu
مع
alaikum.
السلامة. الله يسلمك.